So here, obviously, you have a very pathologic cornea with the epithelium that where you can see the bullous keratopathy and the very irregular posterior surface of the cornea. And adding here the image from the microscope, you can really understand how the pathology that you can see in the en face image is in the structure. Obviously, again here, you can see here the area where the cornea had previous surgery. Well, actually, this was here, and this is the area where the cornea is trephinated in order to to get the new keratoplasty. Just to show you that even with an open eye, you can see how the film of the viscoelastic is filling the anterior chamber. You can see exactly where the previous scar were in order to avoid here exactly the area where the previous trephination was. And this was quite important for this case in order to avoid getting your trephination exactly in this area in order to get later on scarring and healing problems. Then just by putting the new cornea, you can see how the adaptation, the very first adaptation, is putting the first sutures, then the running suture. You see how irregular this is. Obviously, no surgeon is satisfied when somebody sees this. This is at placing the second suture. And to be honest, nobody would, I wouldn't, at least I wouldn't realize how irregular the cornea is while doing this procedure, because you're just used to see this en face picture. And so at the end, you can try to get the best possible positioning, as you can see here, and get the best possible adaptation in this complicated situation where you had an eye that had previous cataract surgery. Let me share with you this case here, where you can see in this marginal pellucid degeneration how thin the cornea is at the periphery, in order, and this is especially useful in order to plan your trephination at an area where the cornea is not that thin. Otherwise, it would be really difficult to adapt your new cornea in this situation, in this place, in this area. Obviously, you see the mirroring of the cornea, but even in this situation, you can see how broad the image is. So this is 12 millimeters from here to here. And so this is even more than 12 millimeters, which is very helpful in various situations. Another case of anterior segment surgery, where you have this severely damaged bullous keratopathy, this severely damaged cornea with bullous keratopathy, and basically keratoplasty decompensation after primary keratoplasty. And you see at the back an iris lens diaphragm. So after removal of the cornea, you see that in placement of an infusion line at the pars plana, you see how dislocated by the infusion line is the iris lens diaphragm is. And actually, you can see here in this OCT image the iris lens diaphragm. Let me stop this for you for a moment to understand what we are seeing. So this here, exactly this area, is this part of the iris lens diaphragm. You can see the optic here, the translucent optic, and here is the rest of the other side of the diaphragm. So you can see the tilting of the diaphragm in with this imaging. And in order to go further in this operation, we needed to to add an corneal keratoprosthesis that you can see here. This is sutured by 6 sutures, and you can see the margin of the keratoprosthesis right here, and this is exactly at this area. I would like to show you this exactly where this is. So this is the keratoprosthesis, goes over the cornea, over the cornea, the scarred cornea, into the anterior chamber here. This is the back of the keratoprosthesis, and here is the other side of this. In order, and this is especially useful to be able to exactly see how the correct placement of this keratoprosthesis is, as you can see here, in order to have a good start of your operation. Obviously, we did this because there was some posterior pole pathology, and we had this severe pucker, as you can see here on this images. You see the epiretinal membrane here. You can see that here, which actually was not visible at all in this detail beforehand. There was no possibility other than ultrasound imaging to see that what the exact pathology was in this patient, and therefore the surgery was done. So intraoperatively, after having placed the keratoprosthesis, the membrane peel was performed, and you can see how the result was just after peeling, and where you can pretty much control what you did with the OCT, and obviously also check whether there was any minute retinal detachment, where actually we thought preoperatively that there was retinal detachment, but as you can see, there was no retinal detachment in reality after having seen. So, and after removal of the keratoprosthesis and placement of the donor corneal button, you see the nice adaptation. Obviously, you can also see the Descemet folds that are normal in keratoplasty, but it is important to see how well adapted is the new corneal button.